Hello, everyone. Welcome. My topic today is how to identify the complex HIV patient. These are my disclosures. I do want to point out I am a member of the guidelines panel, but the opinions I express today are my own. So I'd like to ask, what makes a patient complex for you? I know if you ask enough providers, certain themes emerge. And I think you'll find today that we have a panel of great speakers that will actually address a lot of these different issues. And I'm going to introduce them to you today, and I think the speakers that follow will go into greater depth. So I commonly get asked about patient scenarios, and this is a typical one, where a provider will ask me, I have a patient that has A and B comorbidities with resistance to X, Y, and Z drugs. They have failed 2 prior regimens due to non-adherence, and they're on different medications that interact with their different ARVs. And the patient only has the most recent resistance report because they came from out of town due to unstable housing. And the patient wants to only take ART once a day. And the provider will say, I was thinking about using X, Y, and Z plus U drugs. What do you think? And I commonly will answer, you can try that combination, but it's not been formally studied in this situation. We should get some more information. And the provider will often ask, why hasn't the regimen been studied? What other labs should I get? Well, currently now we have 8 different drug classes and 30 different agents we can use to treat people with HIV. And so the number of possible combinations are quite extraordinary. To drive that point home, I want to just make it a little bit simpler. Imagine choosing 3 desserts from a menu of 10 items. How many different possible combinations do you think you could make with those? Well, there's over 100 possible different combinations. So if you're thinking about starting regimens in a patient that's treatment experienced, and you might be considering 20 different ARVs, the number of combinations are greater than 1,000. But importantly, only a fraction of these possible combinations have been formally studied in randomized controlled trials. So patients living with HIV have many factors leading to complex care decisions. Adherence can be affected by patient comorbidities such as substance abuse, mental health disorders, neurocognitive impairment. Unstable housing and other psychosocial factors can impact treatment. Interruption or intermittent access to ART can affect adherence. Drug adverse effects and prescription errors can impact treatment outcomes. And obviously high pill burden, dosing frequency, and food requirement all make a complex patient, make it complex for patient decisions. So also patients can have many comorbidities that can affect the choice of ART. Now, I don't have time to go through all the ones down on the left side of the screen here. However, the speakers that follow will address many of these. But I do want to encourage you to download this NIH app, as within the guidelines, this is a free app, and within the guidelines themselves, they actually address each one of these different comorbidities and make suggestions of which ART might be useful to try in those situations. So patients that we treat are often over the age of 50, which can add to complexity to the ART decisions. Adverse drug events occur more commonly in older patients than in younger patients. And older patients, we need to think about bone health, kidney health, cardiovascular, and liver health, and we need to monitor them much more closely. In addition, polypharmacy is common in the older patient, and this leads to more likely to have drug-drug interactions. And if you actually have drug-drug interactions, it can decrease the activity of a drug, increase the activity of drug, and all these could lead to adverse effects in patients. There's also HIV-related factors contributing to complexity. Many of our patients have failed multiple prior regimens, leading to very complicated drug resistance patterns in them. Also, some of our patients have transmitted or pre-treatment drug resistance that can affect our drug choices. And some patients are infected with viruses that have innate resistance to some of the ARVs due to viral tropism or the presence of HIV-2 infection. In addition, pre-treatment viral loads, high pre-treatment viral loads can affect the activity of some of the regimens. What about ART regimen-related factors? Some of the drugs have suboptimal pharmacokinetics in some patients, leading to variable absorption, metabolism, and possible penetration into different viral reservoirs. Suboptimal virologic potency also can occur. Many of our aging patients were exposed to early era ART combinations that were less potent. In addition, some of our patients actually were exposed to monotherapy, dual therapy due to the sequential approval of drugs over time, especially those patients that have been infected with HIV for more than 20 years. And lastly, some of the drugs have a lower genetic barrier to resistance. And this really depends on the ARV and the generation of the drug class. So how do we understand what are the variants that are infecting a patient? We have a number of different tools that we can use, and I'd like to walk you through some of these today. So first, when do you do resistance testing? When a patient is on a regimen and they're experiencing virologic failure and their viral load is greater than 1,000, a resistance assay should be performed. If a patient's viral load is greater than 500 but less than 1,000, a resistance assay also can be attempted, but it may not necessarily be successful, but it still should be attempted. And recently, the International AIDS Society and the USA panel recommended that also resistance assays could be attempted if the viral load is greater than 200 and less than 500 copies. However, again, the caveat is that it may not always be successful. And obviously, in patients that have suboptimal viral load reduction after starting therapy, resistance assays should be performed. So how do we test for resistance? Well, genotypic resistance testing is our workhorse in the clinic. These assays amplify the gene regions which encode the viral proteins and enzymes that are the drug targets to look for mutations that confer drug resistance. So drug resistance mutations will be identified in the patient. And most of the drugs, when they go through the FDA approval process, submit the mutational profiles to the different agencies. And these mutations that are identified by the assays actually are given different weights in an algorithm, depending on how much resistance they confer to a drug. And then we use algorithms to actually determine the drug susceptibility. And why do we have to use algorithms? Well, there's over 100 possible mutations that we currently screen with these assays. And so you need algorithms to actually interpret all the different possible combinations that can occur. So strategies that you need to remember when you're using resistance assays. These assays should be performed while the patient is taking the failing regimen or within 4 weeks of stopping the drug. And the reason why that is demonstrated here in this cartoon. These red squiggle lines here represent resistant virus. And in the absence of drug pressure, over time, wild-type virus will outgrow the resistant variants and become the dominant population in the patient's circulation. These are represented by the light blue squiggles here. And why that is important, if a resistant variant declines below 20% of the viral population in a patient's plasma, these resistance assays commonly won't detect them. And that's important because if you thought the patient was had wild type virus, and you put the person on this regimen, actually could end up failing very quickly as a resistant variant that was occult and not detected by the resistance assay could rapidly reemerge and cause drug failure. However, even if more than 4 weeks have elapsed since ARVs were discontinued, resistance testing can still provide useful information, and although it may not detect all the prior drug-resistant mutations present in a patient. So genotypic assays are preferred over phenotypic assays, especially in the patients that are with suboptimal virologic response after their first or second line regimens. However, phenotypic assays actually can add additional information, and these are recommended if the patient has a very complicated resistance pattern. And how phenotypic assays work is they measure the ability of the virus to grow in different various concentrations of ARV. Now, this is usually compared to a reference virus, and so it's expressed in a fold change compared to the control virus. These results usually take 2 or 3 weeks. And the interpretation can be complex, and I would recommend that you consult with a specialist if the results come back and they're difficult to interpret. We also have tools to evaluate HIV tropism. HIV entry involves the sequential attachment to the CD4 cell receptor, followed by binding to either CCR5 or CXCR4 molecules. And then you have the fusion of the viral and cellular membranes. Now we have drugs that actually block the CCR5 receptor. And we need to be able to determine the patient's virus has any CXCR4 tropic variants. And why that's important is you wouldn't want to use these co-receptor antagonists if the patient was harboring CXCR4 tropic virus. And how do we determine that? Well, there's viral tropism assays, and these can be detected for HIV RNA or proviral DNA. And these are done either by phenotypic methods or next generation sequencing of the envelope region of the virus, and then using bioinformatics to predict co-receptor usage. So I want to take a moment and talk about proviral DNA testing, both genotypic resistance and tropism testing. We now have the ability to evaluate the archived proviral DNA in a CD4 cell. And how these assays work is they usually require 4 milliliters of whole blood from the patient. And within that amount, there's about 2 million peripheral blood mononuclear cells in a milliliter of whole blood. However, in that, only about 25 to 50% of them are CD4 cells. So really, in these assays, you're only sampling about 4 million CD4 cells. And in a virally suppressed patient, that might only represent 4 to 40 proviruses sampled. Very nice studies have shown that about only 1 to 10 intact proviruses are present in 1 million CD4 cells in a person that is on that virus is being suppressed by a potent regimen. So you're really only getting a very small sample of the viral reservoir. And that becomes important when you're actually trying to assess the cumulative resistance in a patient. So this is a figure that from a review we did about the management of highly treatment experienced patients. I've updated it with a number of different figures here to really emphasize the points that I've just raised. So if a person's on therapy and they're failing therapy, the first thing you should do is assess for adherence, drug-drug interactions, drug-food interactions, any ARV intolerances, and patient comorbidities that could be affecting why the patient is experiencing virologic failure. You should also look at all the viral load and CD4 cell trends over time. And importantly, you should review the ART history, prior and current drug resistance results, and consider a HIV tropism test. You should take all this information and create a cumulative resistance result to construct a new regimen. And using that information, the new regimen should include 2 and preferably 3 fully active agents, and get expert advice if needed. So proviral DNA genotyping actually can assist in some situations. It can be useful in patients with HIV RNA below the limit of detection where low-level viremia or with low-level viremia and where HIV genotypic assays may not be successful. It can also be used in patients who are experiencing virologic failure for whom conventional genotypic resistance testing is unavailable or unsuccessful. But an important caveat I want you to remember is results should be interpreted with caution, as these assays might miss some or all the previous existing drug resistance mutations. So I want to just touch on a few general principles before I finish. When you're considering a patient with drug-resistant variants and constructing a new regimen, in general, adding a single drug to a failing regimen is not recommended. This may risk the development of resistance to all the drugs in the regimen. Some drugs may have partial activity against the patient's HIV and may be retained as part of a salvage regimen in some patients, and I think we'll hear about that in the following lectures. For some patients with extensive drug resistance, maximal virologic suppression may not be possible. And in these patients, ART should be continued and designed to minimize toxicity, preserve CD4 counts, and delay any clinical progression. Stopping ART is not recommended, as this can increase the risk of disease progression. So in summary, complex factors are patient-specific and may be weighted differently for each patient and must be considered when you're constructing a new regimen. And slide is just supposed to represent how you can weight the different complexities for different patients. But the goal remains the same in all these patients. You want to suppress the viral load to non-detectable levels. You want to construct a regimen that the patient can tolerate, won't have drug-drug interaction actions or worsen any underlying comorbidity, and most importantly, suppress the virus load to non-detectable levels, and get expert advice if needed. And you're very lucky because the speakers that follow are the world's experts, and I think they're going to be able to answer a lot of your questions, and thank you for listening today.